Coming today. We have a special presentation, special in a number of different ways. It's being delivered by two graduates of the program. I want to introduce them to you. Dr. Vo is a graduate 2003. Dr. Herford is a graduate of 1992.
Old.
The sad news is I was here when they were here, so I joined them in company. But they're here to talk about medical marijuana. And I won't give you the long story about how this was arranged, but I can tell you that after we agreed that this would be an appropriate topic, we have been asked no less than a half dozen times by different officials throughout the state, what are you doing to educate physicians on the use of medical marijuana? And the answer was, not enough, not enough. We have very little in the curriculum, at least in this medical school. And one of the things Dr. Vo shared with me is that we're not in any way different. Medical schools in general do a very inadequate job addressing this topic. So it's something that we do need, and for that reason it's being videotaped, but I'm not going to say much more than I can't thank you enough for agreeing to do this for us. It's great to see them back there. Had a little tour, and they were impressed by how things have changed. Again, thank you for your time and your offer to provide this instruction for us.
Thank you.
All right, we're going to tag team this, but thank you all for coming. Just a little introduction. We both are part of the Missouri Cannabis Trade Association, which is a group of, in our situation, healthcare providers who thought it was important for physicians and trainees into medicine, including nurses or support staff in offices, had a better understanding of medical marijuana and its uses and potential complications with the use of cannabis in their clinical settings. So we know that there's a paucity of information out there. In fact, as Dr. Cuddy referenced, only 9% of medical schools in the country actually offer any formal training in medical marijuana, despite the multitude of states who have recreational and medical cannabis laws in place. So that's us. So this, just our disclaimer. Cannabis is still, or marijuana is still classified as a Schedule I drug, so it is illegal from the federal level. So if you get into a practice or a situation where you're employed and they accept federal funds, then you, if you're going to participate in certifying patients for medical marijuana in the state of Missouri, you need to check with your legal counsel there. If you have any questions, I would refer you back to the Department of Health and Senior Services in our state. So in November, the Amendment 2 legislation passed with overwhelming support. And in fact, we got more support for Amendment 2 than they did for any of the Senate candidates, the bingo legislation, and even more than minimum wage changes. What that did is they developed a regulation licensing procedural program through the Department of Health and Senior Services that would allow medical cannabis to be utilized by qualifying patients in the state of Missouri. And 4% of the proceeds from a retail tax would then support veterans care and initiatives. Those programs would help with revenue and funding of those services. It's estimated that over time, the amount of money brought into the state of Missouri will be in excess of $16 to $18 million, with approximately $7 million needed to implement and run the program in the state. So what's a physician's responsibility? I'm going to walk you through that process. I actually practice in Missouri, and I have an Illinois medical license, so I've been certifying patients in Illinois, and I'll give you my perspective on both of those. The physician responsibility is, number one, you still advocate for your patient's health. So it's imperative that you understand what medical cannabis can and cannot do, and that you have the ability to discuss that with some knowledge with your patients. Physician certification means you will just certify a patient. You'll sign an electronic document, or if the electronic document is not available through the state of Missouri, you'll be able to sign another acceptable form stating that a patient has a qualifying condition. So the physician only certifies you're not prescribing marijuana. What it also did is it protected physicians from any civil or criminal liability associated with discussing cannabis or medical marijuana with their patients. And in fact, physician certification for a qualifying condition, if it's done properly, has not resulted in any legal sanctions against physicians. So what happens? A patient will come into the physician, and with their medical records, the physician should review that. It does require a face-to-face evaluation with physicians in Missouri. So the physician documentation will ask for the physician's full name, whether or not they're an MD or DO, where they practice, their license number. They'll ask for the patient's name, their social security number, and then the physician must identify the qualifying condition on that form. Once the physician has reviewed that form, discussed with the patient the use of cannabis, then they can certify the patient if they have a qualifying condition. The patient then takes that certification and they register with the Department of Health and Senior Services. They have 30 days upon receipt of the physician certification in order to submit all their paperwork to the state, and then the state can act on it. Starting June 4th is the first time that physicians can begin certifying patients with qualifying conditions. The state will then start issuing cards saying that patients are appropriate for medical cannabis on July 4th. The patient, once they receive a card certifying their status with a qualifying condition for medical cannabis, then they will go to a dispensary, and the dispensary is where they'll receive different products and have education from the personnel in the dispensary about appropriate uses of certain products and the way to use them in order to treat their condition. I believe, and the physicians on the health committee for Missouri Cannabis Trade Association believe, that physician follow-up on those patients is important, that there's some feedback that's necessary. Patients will respond differently to cannabis. They'll respond differently to the same product at different points in care. So if you really want to have a good follow-up and understand how cannabis works and how helpful it can be, that feedback loop, I think, is really helpful and necessary. As I said before, those qualifying patients can be identified beginning June 4th, so next week. July 4th, the first cards will start to be issued. The cost for patients is $25 for a card. What are those qualifying conditions? So these are state-to-state specific, and this from Missouri includes cancer, epilepsy, glaucoma, intractable migraines, any chronic medical condition that requires the treatment of medications for persistent pain or spasm. MS is an excellent diagnosis to consider in that situation. Parkinson's disease, Tourette's even. If they have a psychiatric disorder such as PTSD, if they have HIV or AIDS itself, any chronic medical condition where they would require the use of a medication that that medication's use may be more dangerous than cannabis, and cannabis may be a helpful treatment, those patients would have a qualifying condition. The opioid patient, the pain patient, would fall under that category. Any terminal illness, or in the professional judgment of a physician, any chronic debilitating conditions such as hepatitis C, ALS, inflammatory bowel disease, Huntington's, Crohn's, neuropathies, sickle cell, agitation associated with Alzheimer's, cachexia and wasting syndromes. So, again, just to reiterate, physicians are not prescribing marijuana. You're not giving a dose. You're only certifying that patients have a qualifying condition. This is the application from Illinois. I haven't seen an application from Missouri, but it'll be somewhat similar. It's an electronic form, or it's intended to be an electronic form. And again, those parts of that application are necessary. The physician has to be a physician in the state of Missouri with an MD or DO. It can't be a nurse practitioner, a physician assistant, an assistant physician, or an RN. It has to be an MD. And they'll identify the qualifying condition. That middle column there is Illinois' qualifying conditions. Missouri's are just a little bit different. Each state is different. And then they'll have their attestations page, which is the third column here, and the physician will sign that. And I've just covered this again, MD, DOs in the state of Missouri with a valid medical license. Here's the timeline for implementation, and just to go over this, there's a little bit of a hiccup for patients. They can start applying for medical cannabis cards in the state of Missouri beginning June 4th. Those cards will be issued July 4th. But you can see on the timeline, facility license applications haven't been accepted. So there's no cannabis dispensaries available for patients right away. It'll probably be early 2020 before we see those. So what is cannabis used for? Well, cannabis use goes back millions of years, and I love this part of any cannabis talk, and we don't have a lot of time, but if you want to be fascinated by some of the medical uses and what has happened with medical marijuana historically, there are great resources out there. But it's been around thousands of years. Cannabis was used for menstrual cycle disorders, anxiety, rheumatism, nausea. The ancient Romans, Chinese, Egyptians had this and was brought over and became westernized through the 1700s and 1800s. Queen Victoria had cannabis prescribed by her primary physician, Dr. Reynolds, for menstrual cramps and rheumatism. In the 1850s and 1854, it was a part of the U.S. pharmacopoeia because many physicians used the plant for medicinal purposes. AMA physicians, by and large, supported the use of cannabis or the parts of the marijuana plant for different conditions. And then things started to change. If you look back, one of the problems with cannabis is it wasn't water soluble, so you couldn't inject it. And there was a lot of variability in how cannabis affected patients. And right about that transition phase between the late 1800s into the early 1900s, other medications for pain became available, morphine. And so there was a lot of use of morphine for pain. And then because there were problems with morphine and a lot of addiction, this great medicine called heroin was developed, and that was used. Those became outlawed very, very quickly, but cannabis fell to the wayside because of the difficulty in using it and the onset of action. And very soon thereafter, for many political reasons, which is just another fascinating talk, cannabis came under fire much like heroin and morphine did. And it was, there was a de facto prohibition of marijuana in the 1930s. And by 1942, the AMA had removed it from the pharmacopoeia. And then we jump forward. In the early 1960s, an Israeli chemist, Raphael Mishulam, was able to identify this chemical, the delta-9 THC, and then later on was able to identify receptors in a special system that Dr. Vo will speak about, the endocannabinoid system. And so isolating this, we began to appreciate there's something much more interesting and perhaps powerful about this plant. And in 1996, California passed Proposition 215, allowing the use of cannabis for medical reasons. Colorado and Washington followed a few years later, and then Missouri in 2018. As I told you before, the Marijuana Tax Act basically was a prohibition of marijuana. It became too expensive for physicians and pharmacists to sell any of the cannabis products for medicinal uses, and really eliminated any recreational use of cannabis at that time as well. In 1970, the Controlled Substances Act reclassified medications or drugs, and cannabis was placed in the Schedule I group. Schedule I means there's no medicinal use with a high potential for abuse. And that classification has been under fire since that time. There have been legislative efforts to overturn that, and they've been successful. Unfortunately, the DEA has not recognized that, and so it's been hard to study cannabis due to the classification as a Schedule I drug. There is a U.S. patent that I believe is now expired as of April, patent 6630507. There's a song. Anyway, that patent was for the neuroprotective effects of cannabis. There are some large pharmaceutical companies who are participating in maintaining some connection to that patent. So the U.S. government did recognize that there was some potential, not for the marijuana plant itself, but from the non-hallucinogenic components of the marijuana plant for neuroprotective abilities. What has happened? So this is outdated. Oklahoma has joined the legislative landscape. 33 states now have medical cannabis laws in place. 10 states plus the District of Columbia have recreational marijuana laws in place. 89% of Americans support medical cannabis for different medical conditions, and 69% of physicians nationwide support medical marijuana. As I told you before, just to go back, only 9% of medical schools actually have any kind of training for cannabis. That means an hour or more. So we're behind with that many states who've passed those laws. It's sad that we haven't put something in place just to educate physicians or residents. There was a recent survey out of Washington University. They found that 90% of residents and fellows had no idea what they would do or how they would use medical cannabis when they went into practice. So I'm glad you all are here. So what happens, you have a plant. That seed is going to be specific to cultivation centers in Missouri. That plant is grown, processed, cured in a cultivation facility. Then it goes to a manufacturing or processing facility itself where the parts of the plant are made into different products or different edibles or vapors or tinctures. And then those products will go into a dispensary. A testing lab will test the product and make sure there are no contaminants there. And also the testing labs will give you an idea of what components of the plants are in the product. So if you have a high THC content in whatever product there is, or a higher CBD, or as we'll go over, there are multiple parts of the plant that can be useful for different conditions.
All right, so I'm going to now go over a little bit about how does medical cannabis work. And let me get this. And then do I just scroll? Okay. All right, so this looks like a very complicated circle, but this is what is seen in a lot of dispensaries in other states that have dispensaries that dispense cannabis legally. So you can see here on the outside there's different illnesses, diagnoses, in the middle, the different cannabinoids. And so this is helpful for people who are working in the industry to have a rough gauge of which cannabinoids help for which conditions. And I'll go over a little bit more about that. So what is the human endocannabinoid system? Like Trish said, this was identified in the probably early 90s is when they really understood it well. There's two receptors, CB1 and CB2 receptors. CB1 receptors are mainly in the brain and the nervous system, and CB2 receptors are in the peripheral organs and in the immune system. This was identified, actually, CB1 receptor was identified at St. Louis University in 1988. What we know is these receptors are throughout our system, and they are responsible for creating homeostasis, so that your body has these different cytokines and hormones, and that when it's one system is off, then the cannabinoid system can help to regulate and create this homeostasis. And what I usually think of is it's similar to, let's say, a mobile. So we have a mobile that at the top is the center of the system, and then we have these horizontal lines and string that then has all these different plays. So when one system is off, the other system has to regulate to get it to this homeostasis. So in modern medicine now, what we do is, let's say a patient has nausea, we treat the nausea, but then we treat the different symptoms of a condition, where that can sometimes have side effects, and patients' then system is off a little bit, whereas we may be able to treat at the center of this system, and that helps with creating this homeostasis. So these receptors work like a lock and key for these different cannabinoids. There's over 100 different cannabinoids. We all know about THC being the one that can cause, that has a psychoactive properties. CBD, you all probably hearing a lot about as far as for its anti-inflammatory properties, but there are very many more different cannabinoids. THC works as a very, the lock and key is direct, whereas CBD and some other cannabinoids work as a modulator. They work in a different way to mitigate the effects of THC. So why is that important? Because we do have FDA-approved cannabinoids. These are synthetic cannabinoids. Dronabinol and nabilone were approved, and they're FDA-approved in the 1980s for chemotherapy-induced nausea, vomiting, anorexia, and I talked to a lot of neurologists who use this currently for patients with spasms and peripheral neuropathy, and they get good effects from that. The problem with these synthetic products is there's a narrow therapeutic window, so it doesn't work as well because, as we say, we're isolating just this one cannabinoid, and it doesn't have these other cannabinoids that are in the whole plant that help to mitigate maybe the side effects of THC by itself. Also, they're anywhere from $1,200 to $1,500 a month as far as the cost of these products. So I have tried Marinol for patients in the past, and it's a real hurdle to get the insurance companies to cover it. And sometimes the patients get too sleepy from it. They can't really, it's not helpful for them. So in June of last year, we did approve a whole plant extract of cannabidiol called Epidiolex. So it is available now. I believe it was January. It's available in pharmacies, but is only FDA approved for 2 severe forms of seizures, Dravet syndrome and Lennox-Gastaut, which are severe seizures in children. The cost of this medication is around $2,700 a month. So I don't see it being really used much, although it's very similar to what we're seeing now on the market as these CBD oils. The difference is that with this medication, it's Schedule 5, and also that it's coming from GW Pharmaceuticals, and it's got the lab testing and the research data behind it. So phytocannabinoids. So we make cannabinoids in our system. We make anandamide and 2-AG. That is created in our own system for our endocannabinoid system. Phytocannabinoids are cannabinoids that are from the plant. And the predominant cannabinoids and minor cannabinoids we talked about, there are very many of them, and they each have different effects. There is ones that cause sleepiness. There are ones that help with weight loss. And so that's where that big wheel comes in, all the different cannabinoids and those properties. So in the past, if you've heard or have been to a dispensary or spoken to people who understand cannabis, you may have heard the terms indica and sativa. These are ways to talk about the different cultivars, the different plants that are out there, different strains, if you will. And nowadays, what we're seeing more is the different varieties based on their ratios of THC or CBD. So, for example, indica in the past was one that would make you very sleepy. Sativa would be more of an uplifting type of cultivar. But now we're looking at THC dominant, meaning the percentage of THC is higher. So those may be more effective for patients who use it for sleep or for pain. The CBD dominant varieties may be better for the inflammatory properties or possibly for the GI effects. And then there's type 2, which is a range of different ratios of THC and CBD. There's also industrial cannabis, and that's what we hear about, industrial hemp, with the recent farm bill that was passed and allowing hemp to be grown and licenses to be awarded for industrial hemp purposes, for industrial purposes. And then the 2 terms, cultivar and chemovar. Cultivar means the different strains or different plants. There are hundreds to thousands of different plants and different strains that have different profiles of these different cannabinoids, and we'll go into terpenes too, but that's what helps. Some people may find that this one cultivar helps for them, and another cultivar may not. There is a term called chemovar, which means chemical variety. So now a lot of times these different strains, we don't want to use just the name. We want to know what is the chemical property. So the plant scientists are looking at that to be able to understand, what's chemical composition, and to identify which one is going to work for what condition. I have met people some business people in California who are working with researchers in Israel to identify which cultivar, which chemovar is best for Alzheimer's dementia, and which cultivar chemovar is best for breast cancer. So that's the new wave of research that we're looking at. Like I said, combining it works better because of CBD being an allosteric modulator of THC. So when we use CBD, it actually reduces the side effects, the psychoactive effects of THC. So there was a research study looking at 300 breast cancer patients in Journal of Pain. And I'm not sure if you saw this, and I think it was in 2015, but it looked at 300 patients. They gave patients 30 milligrams a day THC, and then they had patients really increase, and they found pain relief at 27 to 30 milligrams of pain relief, but they did have the more side effects. And then when they had patients use CBD and THC products, they found their pain relief really was better with less side effects. But they did have to increase the amount of milligrams that's used. So when we consider combining these different cannabinoids and looking at the different products that will be available here in the market, it's going to be looking at the ratios. Like I said, THC, more of the insomnia and pain relief, where CBD is more the anti-inflammatory properties. Different timings, because it'll have to do with maybe you want a higher CBD product during the day for anxiety and PTSD, but you want a higher THC product at nighttime to help with sleep and and pain. And then looking at the total dosage. There's products here will have specific dosages, not the smokable flowers, but specific dosages that physicians can help patients to navigate that. The most exciting part of having medical cannabis here in Missouri for me is this lab testing portion. I have patients who use medical cannabis currently, and they are not able to, they don't have products that are lab tested. So we don't know about the safety. We don't know what the contents are. There may be products out there that claim to have a certain amount of CBD or THC in them, and they really don't. It does vary by state, but as far as in Missouri, there will be testing for THC and CBD, possibly other cannabinoids, and we've yet to see the final regulations. But pesticide testing is going to be very big. Which pesticides are going to be allowed and tested to make sure that the harmful pesticides aren't a part of the plant, and then also fungus and other microbials. There are facilities that have had issues with E. coli in their batches of plants that's been grown in other states. So we talked about cannabinoids. Now I'm going to shift a little bit to terpenes. And what are terpenes? Terpenes are actually the essential oils of the plants. It's what gives the plants their aroma and their flavor. So there are different types of terpenes, and there's so many, I won't go through them, but there are a couple that are that we really know they're in the plant. For example, myrcene is known for its sedative effects, anti-inflammatory effects, and it's also what's in mangoes and lemongrass. And linalool is in lavender, limonene is in lemon, beta-caryophyllene is what's in black pepper, and helps with that analgesic and antimicrobial property of it. Alpha-pinene is similar to the smell of pine needles, and it does have some stimulating effects and bronchodilator effects. But each of these different cultivars have different profiles of cannabinoids and different profiles of terpenes. And so this is an area of research that's going to be very exciting to find out why do some plants work for one person and don't work for another patient, and it may be this terpene profile and looking at that. So Dr. Ethan Russo postulated that there is something called the clinical endocannabinoid deficiency syndrome, where there may be certain illnesses where patients don't make enough cannabinoids in their system and they have certain illnesses. So migraine headaches, fibromyalgia, irritable bowel syndrome, that the patients don't have enough cannabinoids. And some of these patients may try just an isolate of a cannabinoid product, and it might not be as helpful. But what has been found is that this entourage effect is what is helpful, using the whole plant instead of just one single cannabinoid. And we talked about how they work together. And because of not just the cannabinoids, because of also the terpenes that are available in the plant, looking at different combinations to see what is most effective for each patient, and really looking at using smaller doses to help with patients. And smaller doses because there is this dosing curve where we find at low doses there may not be much of an effect. High doses, the higher you go, doesn't mean that your symptoms will be better, your pain will be better. Actually, what we see is that the opposite of that. The higher the dose patients use of cannabis, they may have more and more side effects. And so there is this optimal dose, and having patients really start low and go slow and find that optimal dose for them. And there's this bidirectional effect. Some strains can cause patients to be very anxious, and some may help with anxiety. So there can be different responses in different individuals, and there can be this bidirectional effect can be seen in one individual. They may be using it for their nausea, but at certain dose, the higher they go, actually the more nausea they have. So sometimes the overdoses look very similar to what we're trying to achieve as far as the therapeutic effects of it. So like I said, start low, go slow. When you talk to your patients, I think that's going to be the most important thing, is to say, make sure you go to a dispensary where the dispensary agents are trained and are able to spend time with you to educate you on what to do. It won't be the doctor's responsibility per se to do that, because the patients will be going to the dispensary and getting educated there. But understanding this will be helpful for our patients when they do come back to talk to us. But looking at which strains will be helpful for the medicinal benefit for that patient, and preventing a tolerance buildup by really starting low, going slow, and finding that optimal dose and staying with that dose. There is a sensitization protocol, healer.com. Dr. Dustin Sulak talks about even patients who we may have patients who have been using this for years at a very high dose, and having a protocol over a couple of days where they would stop their cannabis use for 2 days and then start back at low levels, and to be able to dial back and find that optimal dose for the patient. So there are different types of forms that will be available likely in Missouri. There will be inhaled products, which work very quickly but have a short duration. There will be tinctures that patients can use sublingually that will take effect within 5 to 30 minutes but last a little longer. There will be topical products that patients will be able to use, creams that might help for arthritis and for spasms, and then ingestible forms. And I think the ingestibles are where sometimes patients can get into trouble, because it takes a little while for the effect to begin, even up to 2 to 3 hours, but the duration is longer. But I have talked to patients who have taken, so 2.5 milligrams is sometimes like a starting dose. I don't know if you're Right. So 2.5 milligrams may be a starting dose. I've talked to a patient recently who said, I accidentally took 50 milligrams because I kept taking, I was in Colorado and just kept taking it. And he just, it lasted all day. And I've talked to patients who've taken 750 milligrams and, it lasted 3 days. But the main side effects are, where there's mental slowness, fatigue, and not really anything more dangerous than that. It's really waiting it out. Juicing, I don't know much about juicing. I think this is something that's a new in a new market, looking at it for its therapeutic effects without the intoxication, because the intoxication comes in when you heat the plant, and that's where the THCA, which is THC acid, then is carboxylated and has the intoxication. So there's some research looking into that, using high milligrams of cannabis in a juicing method to help with the anti-inflammatory, getting the anti-inflammatory and the benefits, health benefits, without the intoxication. Missouri patients are going to be allowed to grow 6 plants at home. So that is going to be a different certification card. It's going to be $100, and they will be able to send that in and have 6 flowering plants in their home. We talked a little about dosing. I think that it's going to depend on how severe the patient's symptoms are, as well as the size of their patient. But I still believe that we should start low and go slow, and maybe take a day or two on the lower dose before ramping up. And for other dosing recommendations, there is a website called healer.com that does have some information. There's lots of information out there, and I'm also a board member of the Society of Cannabis Clinicians, and they've been around for 20 years, and it's physicians who are on the board who have been educating other physicians and people in the healthcare sector. So, do you want to talk?
Yeah. So, medical cannabis is well beyond the patients seeking this high, and that's some of the misguided information, I think, for physicians, that patients are just going to be slow to react, sleepy, or have the munchies. And as Dr. Vo just indicated, the plant itself has so many different properties, and the way those properties are put together can eliminate some of those negative side effects. In fact, you can actually lose weight with certain parts of the plant and not boost the, the traditional or the conceptual munchies, if you will. So, and there are other ways to boost that immunoprotective effect that cannabis has been linked to, and this is the case with multiple medications. Exercise, what you eat, and other herbal supplements may potentiate or improve the benefits of cannabis for different medical conditions. Cannabis does have some drug interactions, and I think once you get into practice and you're seeing patients to certify them, understanding what those interactions can be. A lot of the anti-anxiety and antidepressant medications metabolized in the cytochrome P450 system should be considered. So one of the criteria for Missouri physicians is that you discuss medications and allergies with a patient, and this is why. So the biggest complaint physicians have, or the biggest argument against medical cannabis, is the lack of research. So this, I think, is probably the most important slide we have. This is a free download. It's a report from 2017 and will be updated. It's 440 pages, and it's not put together by anybody with a pro or anti-cannabis bend. It is, if you're like me and you want the Cliff Notes, you go to pages 13 through 22, and it will summarize all the clinical data from research on cannabis. What they did is they had a group of clinicians, researchers, pharmacists who looked at 24,000 articles and abstracts about research with the cannabis plant. They were able to take out some of the weaker research articles and abstracts and got down to a little less than 11,000 different studies, and they then identified the level of importance of those studies in supporting or not supporting the use of cannabis in different medical conditions, whether it was cardiovascular, whether it was perinatal effects, psychiatric or psychological effects of cannabis, the effect on the respiratory system. And so if you download this report for free, you can pull those up by chapter, or you can look at the whole report. Just to go through it, there was conclusive or substantial evidence that cannabis or cannabinoids were effective in the treatment of chronic pain in adults. There was conclusive and substantial evidence that it was good for the anti-nausea effects in chemotherapy-induced situations. There was conclusive or substantial evidence to support the use of cannabis for spasticity when they asked MS patients whether it was helpful or not. There was moderate evidence that it improved short-term sleep disorders in people with COPD, fibromyalgia, chronic pain, and MS. If anybody in here has worked with a fibromyalgia patient, one of the biggest problems or any chronic pain situation is the sleep disorders associated with pain. So if you can improve sleep, oftentimes you improve pain. They did find limited evidence for increasing appetite or decreasing weight in patients with HIV or AIDS. The clinician-rated spasticity improvements were less significant than the patient-reported improvements. They found limited evidence in treating anxiety and limited evidence in the treatment of PTSD. There was also insufficient or limited statistical evidence to associate any improvement in outcomes in traumatic brain injury with the use of cannabis. This is a really kind of interesting and high-level clinical study that's going on now that some of the cannabis components given to patients with acute nervous system disorders, whether it's spinal cord or traumatic brain, may have a protective effect. So some of that new evidence may change this. At least it looks like it will. By and large, the primary reason that medical cannabis is utilized by patients is for the treatment of pain. And if you go through all those qualifying conditions, pain becomes an important part of many of those, whether it's from MS or fibromyalgia, whether it's pain related to rheumatoid arthritis, or even some of the other nervous system disorders, so stroke and traumatic brain injury. These are some guidelines for dosing from some research. MS, looking at THC content of 10 to 15 milligrams. I would tell you that these are nice guidelines, but every patient is different, and they're that point in life, so their age, other medications, and the other parts of the plant that are used together with not only THC and CBD, but the other endocannabinoids can be really helpful in determining a dose. You have to speak with your patient. I know by and large my patients don't want to feel high, and so trying to adjust that THC dose and get a benefit for the patient does take a little bit of some just feedback with the patient and working with dispensaries. There is medicinal benefit. I can tell you this from personal experience myself, that patients do obtain pain relief. I've been able to discontinue opioids on patients who've been on long-term high-dose opioids or significantly reduce those. We know that in states where they have medical marijuana laws, overdose deaths have decreased significantly. There's an anti-seizure benefit with medical marijuana. We certainly know the nausea relief and appetite stimulation associated with cannabis products. There's anecdotal to limited scientific improvements in some anxiety disorders, PTSD being one of those, and as a sleep aid. It's not as addictive as many of the pharmaceutical alternatives we have. Obviously, the opioid crisis is first and foremost on many of our minds if we practice the way I practice. So in any way we can modify or make changes in that that problem in our country, I think is worthwhile looking into. So again, your patient is going to be different. We don't know all of the interactions of different parts of the plant on different conditions. So that feedback loop, if you choose to work with patients and utilize medical marijuana in your practices, is going to be really important. It'll make you better clinicians. If you have questions, I would refer you back to the Department of Health and Senior Services. That website is easily accessed, and they can give you updates on current legislation. Healer.com, Dr. Vo indicated, is a great resource. It's really easy reading if you're new to the endocannabinoid system or want to know a little bit more. It can walk you through that. There are multiple other resources out there for physicians. Thank you all for coming. I'd like to see more of you. I think this is important, so at least you guys are a start.
Yeah, and it'll be recorded, so it'll be available for the rest of the students and residents, physicians. And I will add that Trish and I are going to be meeting with Dr. Williams, the head of the Department of Health, and the director of the Medical Marijuana Division, Lyndall Fraker, next week. So we're hoping to help there be a collaboration where we can help create some informational tools for the physicians in Missouri.
Any questions or any areas which you would like explored more? Yes, sir.
Talk about low and slow in the dosing. How long do you participate with a patient? 30 days, 60 days before you feel like either I'm going to get some effect or I'm not going to get some effect? Or does it just vary so much?
It does vary. It varies on what you're looking for. So with my patients, if they go into a dispensary, a good dispensary is not going to give them a dog and pony show and sell them a lot of product that they may not find useful or may find too many side effects with. So they'll give them small samples, and I think within 2 weeks. The physicians who are really busy are going to find it hard to see patients and follow up that frequently. So a month is a reasonable time frame. And have a patient keep a diary of the effects and side effects.
I know there's certain medications now that we do educate patients, maybe try half a tablet for 5 days, then increase to 1 tablet, for 5 days. And we do that with other medications now, so we probably would be telling patients the same thing.
And is there a textbook or handbook that's available to physicians, like the little pocketbooks you carry in your white coats, for cannabis?
No, and it doesn't. That wheel is interesting because it's almost, if you want an effect on the GI system, here are the endocannabinoids that might be helpful. But then you have to remember there are other parts of the plant that can improve or limit the effectiveness of those, as well as some of the medications or how active a patient. So it's really feedback loop, that feedback loop with your patient until we have more and more research. And the difficulty with research really does come back to that classification of cannabis as a Schedule I drug. I really am hopeful and optimistic that that will change and that will make it the barriers and bureaucratic limits to studying the effect of cannabis for patients will be taken away.
Yeah, I will say I spoke to Dr. Sue Sisley. She was here in St. Louis, and she has a research center where she's doing PTSD research with cannabis, and she was able to get $2 million of surplus money from Colorado given to her to do this research, and she's able to get cannabis from the University of Mississippi. But and the quality of that was not what she was seeing in other dispensaries, but really going back to, it's very difficult for physicians to get funding for the research and to be able to do the research because a lot of times we're attached to universities or to hospital systems. So it is very difficult. And I think that will change.
I do. Yes, ma'am.
I know you mentioned that the acute effects of, THC, like ingesting too much or taking in too much, are like mental slowness and fatigue. But have there been any trials that show the long-term effects of it, like someone who's been on it for years?
Yes. So if you went to the cognitive decline in adults and the cognitive limits with cannabis in adults is short-term. Long-term decline in cognition has not been demonstrated in adults. That's different for children and adolescents. So there is evidence that younger patients may be affected from a cognitive standpoint long-term.
And it is used there are studies looking at it improving memory, and so we do see it as useful in Alzheimer's dementia, and it's through the acetylcholine receptors. That's where that's been identified as that property.
Sort of in response to her question, in developing brains with adolescents, and these kids have seizures, how do you balance the effect on the brain with the treatment for seizures?
I think that's going to go back to risk versus benefit. And with anything we do, we always look at what is the risk of what we're doing as a clinician versus the benefit. And I think that if the child is having seizures to the point where the medications that they've used have not been helpful, or that the side effects are such that they come to cannabis, then that is where we have to really weigh that risk and benefit.
So when your patient goes to the dispensary and gets the product, how do you know what he's getting? And are these products are there brands, and are they the same everywhere in all different dispensaries and so on?
So the seeds in Missouri will be from Missouri. So the cannabis products you get in the state of Missouri will be different than the cannabis products you'll get in California or Colorado. So it should be the same. The access to the different types of products may vary dispensary to dispensary, as will the amount of education that goes into what the patient receives and how they use it. So from my perspective, with my Illinois patients, I have a relationship with a dispensary that I refer the patients to. So I know that they're getting knowledgeable information provided by people who know what the plant can do and are cognizant of the side effects. And I know that my patients will come back and share that with me. That opportunity is there, but it's imperative for the physician who wants that feedback information to talk to the patients and maybe have some feedback with the dispensaries they might have their patients utilize if they are going to be using medical marijuana for treatment of any of their disease processes.
Yeah, and in other regulated states, we do see the dispensaries have different products. So one dispensary may have the same product as another dispensary, or have a product that it's not available in other places. But it's going to be back to the brands that are going to be here, the the industry to create different products. And really, when I talk to patients who have gone out to Colorado and have used these medicines, they're happy to share that information and say, this is the product I'm using and this is what's helping me. So just really asking your patient.
Yes, sir.
So a lot of times, throughout your presentation, you said, it affects people differently. And then you showed the wheel of all the different kinds of, just the different products and the way the plant grows and their different constitutions. Has something been done in a study that does that for humans, to where every human, it affects everybody differently? Maybe somebody's constitution is applicable to a certain kind of product. Do you know of anything?
It's the sophisticated analysis of the marijuana plant in particular patients genetically is being studied. I don't think that information is prominent enough to deliver it with any kind of quality or standard for use across a patient population, but it's being done. Again, there are so many barriers to the study of cannabis in patients in the United States because of that Schedule I classification, but it's being done.
Yeah, there's a lot of research being done out of Israel and out of the UK. With that one product, Epidiolex, some of our great double-blind placebo-controlled trials actually come from GW Pharmaceutical, and Dr. Ethan Russo is working up there with them. So I think that it'll be time. We'll start seeing more research and more data available, but it is being done, starting to be done now.
And with the amount of laboratory testing and understanding what parts or components of the plant are being utilized by patients, that feedback in a database that is being developed may be helpful across the country.
Because I'm thinking that there's something about pH levels in blood or in people's constitution would be the...
Certainly, the microbiome and the plant products. There are lots of things to consider that may improve or limit the effectiveness of cannabis in certain patient populations.
And there are studies looking at the terpenes as well. For example, if patients eat mango, which has more myrcene in it, actually they can use less cannabis product. With that, eating a mango right before you dose with your cannabis may help boost the effectiveness of the cannabis. So there's a lot of that research going on as well. Any other questions?
I do have a question. Okay, so about the people who are working at the dispensaries, who are they and what kind of training do they receive? Do they receive any?
They should receive it. There are no, as far as I know, and you can answer it, there's no legislation to address the type of education that the dispensary employees must have.
Yeah.
So
I have patients who do ask me that, and I will say to them, in the future when dispensaries are available, call the ones that, call a few of them and ask, what do your dispensary agents, what are they certified in? Are they certified in a certain, there are different places where they can get certifications. Are their staff certified in that? So there's like Trichome University, Medical Cannabis Institute, Healer.com has a training program. And if they say that they don't have to go through any certification, then that was when I would say you make me worried about that.
and medical dispensaries in many states actually lose a lot of money. And I believe the reason for that is they don't have quality training and right.
And understanding. Service is really important in this industry because those dispensaries are acting as we are in the healthcare industry and being there at the front lines to educate patients and to help them with their needs. So it's a pharmacy and a medical clinic all rolled up in one. So
there's no state regulations?
No, yeah.
not this time.
Trichome University is run by Max Montrose, or he is one of the, and he spoke at the MoCan BizCon
Oh,
in March in St. Louis, and they offer literature that, like every dispensary should, they can order it online or through Trichome University, I believe is what it's called, and it's an educational workbook that he talked emphatically about. If you're going to be running a dispensary, this is what you need to know. And boom, big,
I will tell you,
half of a phone book size
I,
thing.
are the patients that will come into a physician with a qualifying condition, especially now, will have more knowledge than the physician and a lot of the new dispensary employees, because they've looked at it, they've lived with this condition, they're already exploring ways to improve it. So it's imperative, at least in my opinion, those dispensaries are prepared, because our patients are educated.
And for physicians who are hungry for more knowledge, there are not a lot of continuing medical education opportunities out there. There is the Medical Cannabis Institute, which I did their training, and I think you can get 10 or 12 credits from that. This presentation that we had, we were able to get CME credit for this presentation, so that's really exciting because there's not that many opportunities out there. Physicians kind of have to really dig on their own and learn on their
Right.
own, read books and look for research trials on their own. Any other questions? Well, thank you all
Thank
so
you.
much for being here.